Hello, and welcome to Quality Care Rounds at Partners Community Health. My name is Rahul, and I am the attending nurse practitioner at Wellbrook Place, and I support both the East and the West Towers. I facilitate these sessions on the third Thursday of every month. Staff can attend either live in person in the Seniors Hub or virtually online through Teams. These sessions are also recorded and made available for staff to access on their own time on the PCH YouTube channel. Now, the goal of Quality Care Rounds is twofold. First, it is a monthly education series that builds knowledge capacity for staff on relevant health topics to improve the level of care for our residents. And second, it creates a platform to engage in meaningful conversations about these topics by clarifying concerns and solidifying understanding. For today's session, we will be discussing aspiration pneumonia prevention. So there are four main objectives to support today's learning. First, we will describe the normal swallowing process, what it means to not swallow safely by exploring different food and drink textures, and then use this information to understand the potential causes for developing aspiration pneumonia. Second, we will identify some of the common risk factors associated with developing aspiration pneumonia, especially for our seniors population here in the home. Third, we will describe the clinical presentation of a resident that we suspect may have aspirated and explain some of the signs and symptoms that staff should assess for. And fourth, we will explain some strategies for preventing and managing aspiration pneumonia in the respective RHAs. So let's start by first describing the normal physiological mechanism for swallowing. It is divided into three phases: the oral, pharyngeal, and esophageal components. First, the oral phase begins in the mouth and involves the initial consumption of food or liquids. The tongue moves this bolus of intake to the back of the mouth, where the soft palate closes off the nasal passages to prevent it from regurgitating into the nose. The second is the pharyngeal phase, and it involves the throat and begins with the swallowing reflex, which is automatic when the food bolus hits the back of the pharynx or throat and begins to move through it. Ultimately, as food descends further down, a layer of cartilage called the epiglottis covers the larynx or voice box like a lid to prevent food from entering the windpipe. Once this occurs, it initiates the third and final esophageal phase, which moves the food bolus down the esophagus and into the stomach for digestion. So ultimately, we consume food with our mouth, it gets pushed to the back and through the throat, and the epiglottis covers the voice box and protects the windpipe to ensure the food travels down the esophagus and towards the stomach. To view the three phases of the swallowing mechanism, please visit the link on the slide. Okay, so what happens when there are issues with this swallowing mechanism? Well, then we have difficulty swallowing food and liquids, which is what dysphagia is. Now, this occurs in a variety of situations, but ultimately, what is commonly seen is that the muscles involved in the swallowing mechanism are affected. So here are some signs and symptoms that may indicate that a resident has dysphagia. The tongue is unable to coordinate movements, so a food bolus cannot be formed adequately and is left relatively undigested in the mouth. The food bolus does not move completely from the front of the mouth to the back, so the resident is pocketing their food. The food bolus moves down the throat before the resident can initiate a swallow reflex, so they cannot direct the safe passage of the food down the appropriate pipe, or the resident's swallowing reflex is slow. Or ultimately, the epiglottis does not close the airway completely, which allows food particles into the lungs and leads to coughing and shortness of breath. So I want to delve a bit deeper into dysphagia, as it is one of the most common causes for developing aspiration pneumonia. In this diagram, we can see that there are several ways that a resident can present with altered swallowing when observed eating or drinking. Perhaps the resident is voicing they are having difficulty swallowing. Maybe the staff notice an increased amount of coughing or changes in breathing while the resident is eating. Weight loss is another indicator that the resident may be eating less, potentially due to dysphagia, so capturing those monthly weights are very important. Maybe the resident is having frequent lung infections, or you notice food pocketing in the mouth after swallowing that eventually drools out, or the resident may be taking an excessively long time to finish their meals. All of these factors may indicate dysphagia, and staff should be mindful of them when doing their daily assessments. Next, I would like to discuss the various food and liquid texture types, as this is important to understand when trying to prevent dysphagia. For solids, there are 4 main types of diet textures. First is regular, which is essentially the green light for the resident to eat anything they like, regardless of its consistency. Regular diet typically requires excessive chewing to create the food bolus before the swallowing mechanism is initiated. Some examples include a sandwich, meats, salads, fruits, and vegetables. If the resident is having difficulty with chewing excessively, they may downgrade to a soft diet, which includes foods that are easier to chew. Next, there is a minced diet where soft foods are cut into small pieces and then consumed. Some examples include ground meats and diced vegetables. The final diet to identify is the puree diet, which consists of mashed foods that require very little chewing. On the liquid side, there are 2 main types. The first is regular, which consists of all types of thin liquids including soup, coffee, tea, milk, juice, and water. If the resident, however, is having dysphagia with thin fluids, then a thickened or more viscous consistency may be sought. There are 3 main varying degrees of thickness, starting with nectar-like, then honey-like, and finally pudding-like. When the consistency is pudding-like, liquids are no longer pourable, and they usually require a spoon to consume. So now that we have defined the swallowing mechanism, the signs and symptoms of dysphagia, and the various diet textures to prevent dysphagia, let's define aspiration pneumonia. First, aspiration is the misdirection of oropharyngeal or gastric contents into the lungs. Meanwhile, pneumonia is inflammation and infection in the lungs. So naturally, aspiration pneumonia is the inflammation and infection of the lungs that is caused by aspirating food, liquids, or secretions. So what are the common causes of aspiration pneumonia? The first and most common one is food and liquid intake. A resident may aspirate on their consumption of food due to dysphagia or accidental misdirection of oral ingestion. In this case, the resident may not have dysphagia, but the food inadvertently went down the wrong pipe. Another common cause of aspiration pneumonia is the ingestion of oropharyngeal secretions or gastric reflux. When these secretions are colonized with bacteria, it produces an infectious response in the lungs. Therefore, aspiration pneumonia occurs when regurgitated gastric contents, oropharyngeal secretions, or food and liquids are inadvertently directed into the trachea and subsequently into the lungs. As the bacteria and other microorganisms become part of an infiltrate within the lung tissue, the resulting effect is an infection in the lung, which is known as pneumonia. So what are some risk factors for residents potentially aspirating and developing pneumonia? Well, let's break it down into 4 categories. The first is related to swallowing. If a resident has difficulty with this mechanism, they are at an elevated risk for aspiration pneumonia. Unsafe feeding practices is another factor where the resident is not sitting upright during eating or for at least 30 to 60 minutes post-meal, or perhaps too much food is consumed in one spoonful, or maybe the diet texture is not appropriate for the resident's needs. Dental issues can also contribute to swallowing challenges. Many residents wear dentures, and perhaps they are not fitted or placed appropriately, or the resident has lost several teeth, all factors that increase the swallowing risk and potential for aspiration pneumonia. For consciousness, the resident must be awake to safely swallow, so any changes to that increase their risk, just like sedating medications can make them drowsy and not eat or drink safely, so the food may go down the wrong pipe, leading to pneumonia. Some other risk factors for aspiration pneumonia include the resident's medical conditions such as having dementia, neurological disorders such as a previous stroke, recurrent seizures, or multiple sclerosis, or neuromuscular disorders such as Parkinson's disease and ALS. Ultimately, all of these conditions can make swallowing more challenging and increase the risk for aspirating food intake or even your own secretions. Head and neck tumors and gastric reflux are additional medical conditions that elevate the risk. Some other factors include older age, related to cognitive changes that may affect swallowing and cause muscle weakness. Also, any condition that increases the volume or bacterial burden of the oropharyngeal secretions when the host defense mechanism is impaired may lead to aspiration pneumonia. So, residents that previously had chemoradiation or are immunocompromised are at risk. Now, many healthy adults commonly aspirate small amounts of oral secretions on a daily basis, especially when eating or sleeping. However, if the immune system is intact, our normal defense mechanisms can clear it and pneumonia does not develop. This can be challenging, however, with advanced aging. And finally, having an artificial feeding tube where it is in your stomach or small intestines can also elevate the risk of the contents regurgitating or inadvertently being misdirected to the lungs. Some subsequent slides will expand on the general safety practices associated with feeding tubes to prevent this. So how do we assess a resident that we suspect may have aspirated? Well, to begin, many of the symptoms of aspiration pneumonia are the same as pneumonia caused by a virus or bacteria. Therefore, a comprehensive health history is vital to help distinguish the potential cause of the suspected pneumonia, as management can be different. In the history, you want to identify some of those risk factors that we just outlined that are associated with feeding challenges and swallowing difficulties. Typically, the resident will have a sudden onset of symptoms, or they may evolve over a short period of time, such as hours. Symptoms are usually respiratory and may include shortness of breath, a cough, and potential loss of appetite. When you examine the resident, the vitals may destabilize rather quickly. Residents often will spike a fever, their pulse and respiratory rate elevate, and their oxygen begins to desaturate, often into the 80s. These should all be red flags along with the history that the resident may have aspirated, and an urgent referral to the NP or MRP is necessary. Further, the resident will endorse a cough. It is usually productive or wet, but may be dry if the aspiration is mild. The resident may also have bad breath or halitosis, and they may be seen continually trying to clear their throat. They may also complain of chest pain if they are alert. The breathing can be labored, where accessory muscles are used to support respiration, and when auscultating the lungs, air entry to the bases will be decreased, and you may hear rails or crackles. If they are loud and few in number per breath, they are likely coarse, whereas fine crackles tend to be softer and more frequently heard with each breath. Either way, this is an indication that fluid may be in the lungs and it requires immediate intervention. Some other findings on examination may include the resident feeling fatigued or tired, basically not behaving at their normal baseline, and their fingers and toes may have decreased circulation and oxygenation, leading to coolness. So next, we will have some self-review slides that discuss various stages for preventing and managing aspiration pneumonia. So we would like to take this time to provide a brief overview of the PCH choking policy in case you witness a resident potentially choking. The policy reference number is on the slide, and it breaks down a partial obstruction leading to choking or a complete obstruction. If the resident is coughing, breathing, or talking, this may indicate that only part of the airway is blocked, and staff should encourage the resident to cough forcefully to try to expel the item blocking it, namely food. However, if the resident is not able to do so, or they quickly decline, review the resident's code status and call the emergency medical services if appropriate. For a complete blockage, this is life-threatening as the resident will not be able to breathe. Again, verify the code status, and if full code, ask a bystander to call EMS and get an AED, but do not leave the resident's side if possible. You can use the Heimlich maneuver to try to dislodge the obstruction, but if the resident is not breathing or is unresponsive and they are full code, immediate CPR should be initiated until emergency services arrive. I would encourage everyone to review this policy for more details. So to summarize today's learning, we discussed the normal swallowing mechanism and how it involves three phases: the oral or mouth, pharyngeal or throat, and the esophageal phases to successfully coordinate safe swallowing. Any issues with this mechanism leads to dysphagia. Next, we describe the various types of solids and liquids textures that residents may consume. The more difficult it is for the resident to chew or swallow, a softer and thicker diet is typically recommended to prevent aspiration. Third, we define what aspiration pneumonia is, specifically a lung infection caused by the misdirection of foods, liquids, or secretions colonized by bacteria into that area. Fourth, we identified various risk factors for developing aspiration pneumonia, such as changes or challenges to the swallowing mechanism, alteration in consciousness, which makes swallowing unsafe, and several medical conditions that may compromise the swallowing process. Next, we describe the typical clinical presentation of a resident that we may suspect has aspiration pneumonia, with many symptoms similar to other types of pneumonia. The main distinguishing feature is the history, where we identify some of the aforementioned risk factors. We then had some self-review slides that discuss some important considerations for safe feeding practices. They also review feeding emergency red flags, the PCH choking hazard policy, and some considerations for goals of care conversations with residents and their family. Finally, there is a review of the various types of artificial feeding tubes that some of our residents have, a discussion of the safety plans, how to troubleshoot issues, and a description of some of the general care guidelines for maintaining their safety. Thank you for listening, and I hope this information was helpful to support your practice. We look forward to seeing you at the next Quality Care Rounds.